very good morning to everybody. I will be speaking on the etiology of persistent epithelial defects. So, the underlying etiology can be classified as defective epithelial adhesion, limbal stem cell deficiency, idiopathic and hereditary disorders, inflammation, neurotrophic and mechanical causes. So, this is a cross-section of a patient with a persistent epithelial defect, and this is a cross-section of the normal cornea. So, defective epithelial adhesion is primarily seen in recurrent corneal erosions, which is due to foreign body or giant papillae, which is the most common cause. And the less common cause is epithelial basement membrane dystrophies. Again, toxic keratopathies are also quite common. The other causes like Salzmann nodal degeneration, band keratopathy, bullous keratopathy, vitamin A deficiency, scarring and trauma usually result in defective epithelial adhesion due to abnormal basement membrane production. Thank you. So, defective epithelial adhesion is due to a defect in the epithelial adhesion to the underlying basement membrane. It may be due to deficient or abnormal basement membrane, overproduction of matrix metalloproteinases, and disruption of the migration of epithelial cells. As you can see, these are illustrative cases where we have the defective epithelial adhesion due to foreign bodies or giant papillary conjunctivitis, or due to epithelium node, or due to epithelial basement membrane dystrophies, in which you have a deficient or abnormal basement membrane growing into the epithelium, which causes a disruption in the migration of the overlying of the epithelium outwards. Limbal stem cell deficiency. Limbal stem cells are the mother load of corneal epithelial cells. Hence, in situations like limbal stem cell deficiency, there is no way the epithelium can regenerate. Hence, they are extremely challenging to treat. The most common causes are alkali-induced chemical injury. You can also have primary limbal stem cell deficiency or trauma. Again, these are illustrative cases of alkali-induced chemical injuries, and the result, as you can see, is conjunctivalization of the cornea. Again, inflammation can be very challenging to treat. Again, in the cases of recurrent, in the cases of the inflammatory mediators being there, like the IL-1 or TNF-alpha, which upregulate matrix metalloproteinases, there can be a difficulty in the regeneration of the basement membrane. Hence, epithelial growth and regeneration can be a challenge here. So, you have a host of causes here, like keratoconjunctivitis sicca, rosacea, infectious keratitis, autoimmune diseases, Sjogren's syndrome, mucous membrane pemphigoid, Stevens-Johnson syndrome, graft versus host disease, PUKs, Morin ulcers, and rheumatoid arthritis. Among these cases, the mucous membrane pemphigoid, Stevens-Johnson syndromes, and graft versus host disease can be particularly challenging to treat. Again, as I said earlier, the mechanism is primarily overactivity of the cytokines, TNF-alpha and IL-1, production of growth factors by keratocytes, proliferation and migration of epithelial cells, and stromal remodeling. Again, this is a case of ocular graft versus host disease with a PED in the right eye. Again, this would require a prolonged treatment. Neurotrophic causes. Again, damage to the ophthalmic division or trigeminal will generally lead to neurotrophic ulcers. Again, the damage to the ophthalmic division or trigeminal will lead to decreased blink rate, a decreased secretion of tears, and decreased secretion of the meibomian, decreased meibomian secretion, among other things, and degeneration of tissue. The most common causes here tend to be diabetes mellitus, severe dry eye, current or past hepatic keratitis, anesthetic abuse, and traumatic or post-operative nerve damage. Again, this is a case of a neurotrophic ulcer in a stroke patient, which is again a great challenge to treat. Among the mechanical causes, they also tend to be extremely common. Again, you have lagophthalmos, entropion or ectropion, trichiasis, blepharospasm, pseudomembranes or tarsal scars, trachoma, severe dry eye disease, Sjogren's syndrome, hepatic infection, chemical or thermal injuries resulting in burns. Again, the mechanism is recurrent abrasions that can lead to depletion of the epithelial cells faster than they can be regenerated. Dry or inflammatory ocular surfaces or corneal erosion from eyelid abnormalities will also worsen the condition. This is again cases of entropion and lack of thalamus. As you can see, there's a PED forming inferiorly. Idiopathic and hereditary cause disorders like aniridia and corneal stromal and epithelial basement membrane dystrophies. Again, the mechanism here is deficiency of limbal stem cells and abnormal basement membrane adhesion. Aniridia with primary LSCD and mapped fingerprint are typical examples. Yes. Thank you.